begin the discussion of blood pressure, it'd be nice to go ahead and just get started with the discussion of the varying points that you can actually feel a pulse. Those pulses where you feel your common carotid and you feel your blood vessel expand and contract. You feel it in your radial artery, you feel it in the popliteal, femoral, you can feel it in the back of your foot, you can feel it in the upper portion of your arm. All of these, you're really feeling for an artery. And all those expanding and going down is really caused by the blood surging and going back, aka blood pressure. Now, blood pressure varies wildly in the aorta and the arteries and the arterioles. You can see that it can start off really, really low. It can be really high, or in this purple line is indicating an average blood pressure. But as you get away further and further from the heart and down into the arterioles and they go off into the wild blue yonder, those blood pressures start going down. Blood pressure is determined by how much blood you have, aka blood volume, how's your cardiac output, and the vascular resistance. The higher the blood pressure, the more flow you got going out. This one's showing how quickly blood is going. The black line is indicating how fast blood is going, while the green line is indicating how much area is covered by these different things. You can see that the blood pressure, the flow of this blood is really fast, but once you get to the capillaries, they drop dramatically, but slowly get back up to speed. It is auto-regulated, meaning that you don't really have any control over it, but we'll get into that in a little while. Let's talk about the difference between systolic pressure and diastolic pressure. I'm pretty certain most of you have heard of this terminology before. The systolic pressure is the tippy top pressure, the tippiest pressure that you will see in an artery, while the bottom pressure is that of diastolic pressure. That one is contributed by the reservoir, the elastic reservoir talked about in the elastic arteries as well as in part the muscular arteries. If we break down the word, sys just means that it's the max pressure. Dia means the flow or the flow through, so it's just the simple gentle flow for diastolic pressure. With that, you probably want to know how we determine blood pressure. Let's go ahead and take a look-see at how we figure out blood pressure. So blood is flowing on, no big whoops, no big worries, yay, everything is a laminar flow. A laminar flow means that you really can't see a disturbance. Have you ever tried recording a water stream at different frames per second? You might notice that the water doesn't look like it's moving. It's frozen, yet it's still moving. What happens is now you apply your sphygmomanometer. That's a really fancy word for blood pressure, sphygmomanometer. You apply the sphygmomanometer, you push it really, really tight until finally the outside pressure that you're applying to it, it's much greater than the blood pressure itself. So you don't hear anything. There's no noise. This is before systolic. You finally start releasing a little bit of air from the sphygmomanometer, the blood pressure cuff. And the first noise that you hear, that turbulence, it means that the outside pressure is no longer greater than the blood pressure, and blood is starting to flow. And that systolic pressure, the ventricle finally being strong enough to push open that artery, has made turbulence. So the first noise you hear is your systolic pressure, your max BP. It continues to make turbulence as you release that pressure slowly and slowly, until finally there's one last bit of turbulence, and you wait maybe a millisecond to make certain that was the last one, and then that last millisecond later is your new diastolic pressure. The diastolic pressure, that end turbulence, the turbulence that you hear is partially due to that last bit is due to an arterial reserve. If you remember the reservoir, remember that the elastic tissues really do like pushing back, kicking somebody in the bum as they exit the door. And then finally returns to normal. And they were close to laminar flow. That's how a blood pressure works. That's how you read a blood pressure. Systolic is the first max pressure that's able to push open past the blood pressure cuff, your sphygmomanometer. And diastolic is the last time that you actually have some type of resistance against the walls that would cause turbulence. So systolic, diastolic. Systolic is the first noise. Diastolic is that last noise, or the last second after that last noise. And then the nice normal flow, laminar flow, is after that. Blood pressure, aka, can be considered hypotensive or hypertensive. Hypotensive would be below a certain degree, about like 80 for systolic. Pre-hypertension is between 120 to 139. Stage 1 hypertension, 140 to 159, although this is being debated and discussed whether this is a healthy blood pressure or not. And then stage 2 is greater than 160 for systolic. Diastolic, less than 80 is fine. Pre-hypertension, usually don't see any changes in diastolic unless there's some type of vascular issue. Systolic is usually due to the heart doing a little bit of extra work with viscosity or something. But here's some things that really do affect the blood pressure. These four we just discussed about the venous return. If you have a lot of blood volume, if you're exercising those legs and pumping that blood, you're breathing nice and easy, you're pushing that blood back. Maybe you have some venous constriction. Maybe some of that smooth muscle, that little bit of smooth muscle is doing its job finally. You'd have a parasympathetic or a sympathetic response regulating the heart rate or the stroke volume, all of which combines down into cardiac output. You could also have some work done by the arteries and veins themselves as well. That determines resistance, which resistance we're going to talk about in a little while. But first, let's talk about this really important number. This is a very important side note. Talking about blood pressure. Mean atrial pressure is actually the significant number. You can look at 120 over 80, 120 over 60, what have you. But that doesn't really tell you exactly how well the blood is flowing. Are you getting the blood to where it needs to be? Are you getting blood into the capillaries, and are you getting perfusion? Perfusion meaning you get nutrients across and waste products back in. Mean atrial pressure, arterial pressure, forgive me. Mean arterial pressure is determined by this little equation right down here. Systolic pressure minus diastolic pressure divided by 3. All of that added by diastolic pressure. If you calculate this and you get a higher number map or a MAP, mean arterial pressure, greater than 100, that's bad. That's too much pressure. You're doing some bad things to your body. If you get a mean arterial pressure less than 70, then you're not getting perfusion into the vital organs, and that's a bad thing. Remember, perfusion is getting the nutrients in and the waste products out. Let's do a quick couple of calculations together. So we have a blood pressure. We took a blood pressure, applied our sphygmomanometer, and we got a systolic of 120, a diastolic of 60. We plug in those numbers, and we get ourselves 120 minus 60 divided by 3. 60 divided by 3 gives us 20, so 20 plus 60, and we get a map of 80. Not bad. It falls within the range. We're getting vital organs perfused, but we're not damaging our vascular structures. Let's try 150 over 60. We got sys minus diastolic divided by 3 plus diastolic. Plug that in. 90 divided by 3 is 30. 30 plus 60 is 90. Okay, so let's go ahead and apply these calculations real quick to the ideal BP, what we consider high systolic and what we consider low BP. So ideal BP, we run through the calculation, we get a 93.33 map, a mean arterial pressure. High systolic, you can see that 140 does start going in that warning region, while low BP drops us below that lower border of 70. Now again, here are the factors that really affect the blood flow. If you remember our little chart, you could really summarize it by cardiac output and resistance. You can calculate cardiac output by dividing mean atrial pressure by resistance, but what I'm trying to say is this is more of an FYI. You can calculate resistance based if you know what your cardiac output and the mean atrial pressure are, which is nice because you can tell how much these arteries and veins are dealing with, which is a good number to figure out if you're trying to figure out cardiac issues. But not a huge thing for us here. What is important though is understanding it's not just an FYI. This is something you need to know is what vascular resistance really is. Resistance is, you remember how there's that elastic band? It really, really wants to snap back into place. Well, when you stick your fingers around that elastic band and you pull, you can feel that elastic band really trying to fight back. That's sort of vascular resistance. That elastic tissue is really trying to fight against that blood and push it back. And there are three main factors. If you go down here, 1, 2, 3, these three main factors determine resistance. First, the size of the blood vessel lumen, aka how wide is it? What's the diameter of the blood vessel lumen? If it's really, really small, it's going to offer a lot of resistance. Kind of like you putting your finger over the end of a hose and letting just a little itty bit out at a time, it's going to really put up that pressure. Blood viscosity. If it's really thick, your poor little heart's going to have to push really, really hard just to move your molasses blood. And finally, how far does it have to push it? It's probably easier to push yourself a mile versus a 27-ish or whatever the marathon mile distance is. The longer the race, the harder it goes. The more resistance you're going to see. Now, how do we control BP? How do we know we're going too fast or going too slow? If we go down here, we can see that there's the brains does a good portion of it. You got down here the medulla oblongata, maybe a little bit of your hypothalamus, your cerebral cortex checking it out. But you also have those three different types of receptors. That's measuring proprioception, aka what is the positioning of your joints. Your baroreceptors, aka the things that actually check pressure. A barometer checks pressure outside. And then you got the chemoreceptors. Chemoreceptors check to see if you're really circulating out that CO2 and oxygen nicely. If you're not, then oh dear, maybe something's wrong with your blood pressure. If any of these see something off or awry, it's too high or too low, it's going to do certain things. If it's too high, well, let's ease up on it. Let's send up what goes on Vegas stays in Vegas, brother. You don't have to worry about anything. Nothing's going to get reported. You're good. If you're too relaxed, you're not getting enough blood, then you got two other things that are going to do things. You're going to get a cardiac accelerator that's really pushing up the cardiac output, and then you're going to put in some resistance. You're going to constrict some blood vessels to really get it going, increase that blood pressure, and get it perfused through. Remember, you want a mean atrial pressure between 100 or 70, and if it's below 70, you better get that blood pressure up so you can get some more perfusion going. This is a negative feedback loop, both for increased and decreased blood pressure. If you have an increased these baroreceptors, which by the way is really important that you know where these baroreceptors are. You got two in the carotid bodies. You can see them marked off here and there in carotid bodies. There's checking to see if there's any extra pressure. You also have one in the aorta that's sensing for pressure. If it's too high, it's going to fix that. If they sense high pressures, these carotid sinuses or this body in the aorta senses something, it's going to send an information to the medulla oblongata, which will cause depending on if it's too low or too high. If it senses an issue in decreased pressure, it's going to send a sympathetic response, which causes an increase in cardiac output and an increase in vascular resistance, which increases the blood pressure, which is a great thing, especially if you have a high issue of losing blood, hypovolemic shock. Here are some hormones that regulate blood pressure. Epinephrine, norepinephrine, it makes sense that they would increase your heart rate. You're going to use that for a cardiac emergency. You're going to stick somebody with epinephrine, norepinephrine, try and get that heart rate going and going up. Increase that cardiac output. If you want to dilate or constrict, there are these hormones, which we will get into a lot more description when we're talking about water electrolyte balance. Then we got the blood volume. Again, this is a lot of stuff that we'll be talking about when we're talking kidneys and electrolyte balance. There are several types of shocks if things just don't go right. You've pushed in all the buttons to do the correct negative feedback, but for some odd reason it's not working out so well. You got the hypovolemic shock. Hypo, remember, means low. Volemic means low volume, so hypovolemic means low blood volume. You've lost a lot of blood. You got cardiogenic, vascular, and obstructive as well. With that is about it. Here's some signs and symptoms for shock. Cool, clammy, pale skin. You're not getting the perfusion you want. Your heart's really pushing. Your sympathetic response is really pushing your heart to try and increase its cardiac output, but it's not doing so well. If that's the case, it very might well be that it's not doing so well. It's not, maybe if it's a hypovolemic shock, you don't have enough liquids to really cause a good strong pulse, so it's nice and weak. Sweating could become an issue. Hypotension, especially if it's hypovolemic. It's starting to give out, possibly. That could be very bad. If you see a child's heart give out, then that's a very, very bad situation. Altered mental status makes sense. This is all FYI, by the way, signs and symptoms. You're going to learn that when you get into the nursing classes. Altered mental status makes sense. If you're not getting enough perfusion, your MAP is down below 70, you're not getting enough nutrients to your brain, which can really mess with their functionality. You can't pee if you're not getting enough liquid there. One response will be thirst. Another one will be acidosis because, again, you're producing some acids that you can't really get rid of. Your metabolism always kicks out a bunch, is always making acid, and you have to get rid of it. And that is it. We will be discussing here in a little while the varying different types of circulatory routes, the different types of the names of the arteries and veins, what is the hepatic portal circulation, what is the fetal circulation, all that wonderful things.